That was too much of an introduction. Thank you. Thank you, JP. Anyway,
we'll go to the program now.
Yeah.
Susan, just a minute. Before we start the program, let me ask Ria to share the names of her co-PGs with her who are also attending this session, so that Madam can ask
questions. Yeah. Okay.
Ria, can you please share the names? Just tell the names of who are available on the platform right now. Ria, are you there? Ria? You are not seen on the screen.
I see. What I know is Rahul, Vishnu, Gauri, and Chinnu Nanikitone.
Okay, ma'am. Rahul, Vishnu, Gauri, and Chinnu.
Am I correct, Gauri?
Yes, sir.
Yes.
Okay. So over to Susan, madam, we can start the session now.
Yeah, I consider this as a proud privilege for me given by IAP Kerala for this to be with you all. And as rightly said, Kottayam is my alma mater, and whenever I get an opportunity to be in Kottayam and with people from Kottayam, I feel, doctors, colleagues from Kottayam, I feel very happy to be sharing whatever knowledge I am having about this topic. And I think without much delay, let me congratulate Jose and the whole IAP Executive Committee and team members of Kerala IAP, as well as Kottayam IAP under the able leadership of Murari, Darli and all, for hosting such a program, which is actually going to be of immense benefit for postgraduate students from all over the state. So let us now start. I welcome Ria for having her presentation so that we can have discussion going on. And Ria, I will be trying to interfere in between, and we will go step by step so that we will have a fruitful discussion. So you can start now.
Thank you.
You can start sharing your screen.
Krishnamohan, Susan Madam, Ria to back a muti our phone, Langala 7 4.
Host, main host, Ranjit and Paraya.
Manu. Presenter
ICH Kottayam. ICH Kottayam.
Ria and ICH Kottayam.
Okay.
Host disabled participant.
Manu, Ria and ICH co-host.
Aqua, sir. 1 second. Ria, you can share your screen.
Hello, am I audible?
Audible.
Yes, you are audible.
Good evening. So starting on the presentation. Presenting a 3-year-old girl from Nerimangalam, Ernakulam, who presented with complaints of fever, vomiting and loose stool since 2 days, and facial puffiness and lower limb swelling since 1 day. History of present illness. Child known case of nephrotic syndrome on alternate day steroid.
Hello, please continue.
On alternate day steroid at 1.5 milligram per kg per day for past 2 weeks. Now presented with complaints of high grade intermittent fever, which subsided on taking paracetamol. and complains of 4 episodes of vomiting associated with nausea on the same evening. Vomitus contained food particles. It was non-bilious and not blood-stained, and the vomiting subsided after the first day of illness. No history of any food intake from outside. She had complaints of 3 to 4 episodes of loose stools later that night, which was foul-smelling, watery inconsistency in large quantities with mucus. No history of any blood in stools. Child was then noticed to have facial puffiness on the next day, which was more during the early morning hours and decreased by evening, and progressively increasing lower limb swelling and abdominal distension. She also noticed to have passed high-colored urine with a reduced urine output and frothing of urine by the mother, and no history of any painful micturition or reddish discoloration of urine, no history of redness or pain over the abdomen, no history of headache or blurring of vision, no history of altered sensorium or seizures or limb weakness, no history of any cough, fast breathing, or chest indrawing.
Okay, Ria, so let us stop here. And so what do you think is the problem that we are facing now with this child? Can you just try to find out the issues that are there in this child from whatever you have presented?
So this is a 3-year-old girl child who was known with nephrotic syndrome. She was already on alternate day steroids, and now she has presented with...
No, don't present it again. So here is a child with nephrotic syndrome on a high dose of steroid.
Yes.
And you have given it as 2 weeks. And prior to 2 weeks, how much steroid she was on or whether she was off medications, we are not sure. So she is a case of nephrotic syndrome. That itself is an immunocompromised state. Plus the child receiving steroid makes the child more immunocompromised. And such a child is presenting with an episode of fever with loose stools and all. So do you think what do you think is the etiology of this problem?
It could be a spontaneous bacterial peritonitis.
No, straight away don't go for spontaneous bacterial peritonitis. Child with nephrotic syndrome on steroid is presenting with an acute diarrheal illness. Yes. Possibly it is a diarrheal illness. Possibly, do you think it is a viral or a bacterial?
Probably a viral illness.
Why do you say it is viral? Child is having very high grade fever. Child is having a foul smelling stool, you have said. There is no blood in stool, but still that foul smelling stool and very high grade fever and multiple episodes of vomiting occurring in a nephrotic child who is already immunocompromised and also on a high dose of steroid is making us little be on our alert, because this child is not having a simple illness. So this is what you are going to understand from whatever you have presented. Why are you presenting so many negative histories? What is the importance of those negative histories?
There is no history of any painful micturition to rule out UTI or any reddish discoloration of urine, also seen in cystitis, or it may be seen in a complication of nephrotic syndrome like renal vein thrombosis. Then no history of redness or pain over the abdomen to rule out spontaneous bacterial peritonitis.
Okay.
No history of any headache or blurring of vision. It may be caused due to severe hypertension that may be seen associated with nephrotic syndrome as a
hypertension, or it could be
is the other complication. Venous thrombosis.
Yeah, okay. Venous thrombosis that may be there. Okay, then.
No history of altered sensorium, seizures, or limb weakness.
Okay.
For cerebral venous thrombosis.
So you have taken a history, a negative history pertaining to some problems that can happen in a nephrotic child. You have covered that. That is good. Okay. So you are having at your in your mind, you are having a child 3 years, known case of nephrotic syndrome, immunocompromised, who is presenting with a febrile illness associated with loose stool. So let us now move forward.
Okay. So the child had persistent loose stools and was taken to a local hospital, treated with IV fluids and IV medications. Loose stools reduced, but the edema progressed and was referred to our center for further management. The mother reports that the child then became drowsy and had cold peripheries after reaching the hospital. She was told to have a low BP and was started on IV fluids and medications. Her sensorium became normal after a few hours and was restarted on daily steroid. An albumin was given for 3 days. She improved gradually and was shifted to ward. Edema gradually reduced. BP was being monitored, and she was told to have high BP, and it became controlled with adding a new medication.
Okay, so at this point, what is the evolution of events that has happened, and what is your impression on that?
Her illness has progressed to probably a hypovolemic shock.
So this child became drowsy, and the child had cold peripheries and was having a low blood pressure. So can you tell us what could be the cause of such an evolution in this child who is already treated with IV fluids, IV medications, and after the loose stool subsided, still the child is going into shock? What is the problem? So what are the thought process that you will be having now?
Probably progression of the edema that led to fluid shifting from the intravascular to the extra.
No, but edema progression is part of the illness. Edema progression is part of the illness. So the loose stools is subsiding, and the child is then becoming drowsy with cold peripheries and all. So why the child is becoming drowsy, why the child is going into shock at this point, what are the DDs that you will be considering now? Or rather, I will put it in this way: what are the causes of shock in a nephrotic child?
Since he was on steroid for a long period of time, she might have a HP axis suppression.
Is that the first thing that you will be telling? Say the differential diagnosis in the order of importance or order of the common happening first.
Hypovolemia.
But the loose stools have subsided, no? What are the causes of shock? Let us look at approach it in this manner. What are the different causes of shock in a nephrotic child? So I think I will not ask you more. I will ask Rahul. Where is Rahul? Rahul, please unmute yourself and give your thoughts on this question. Rahul is there. Vishnu.
Madam?
Yeah, Vishnu, can you answer? What are the causes of shock in a nephrotic child?
Madam, the disease process itself, the hypoalbuminemia.
Yeah, hypoproteinemia. Okay, hypoalbuminemia leading to underfilling of the vasculatry. Underfill. Okay, underfilling of the vasculatry. So hypovolemia, I agree. Okay.
Then excessive proteinuria leading to ENaC activation in the tubule.
Don't say that. That will lead to overfill.
Okay.
That will not lead to shock. It will lead to hypertension.
Okay.
So in this particular situation, high-grade fever, foul-smelling stools, immunocompromised host.
Septicemia,
yeah, septic shock. So you have to, septic shock. So hypovolemic shock, septic shock, and as Ria was telling, it could be an HP axis which is suppressed, and HP axis suppression. So with these points in our mind, we have to proceed further. So before that, let me ask, why the edema increased? Why the edema increased? Vishnu, can you answer? Edema progressed, loose stools reduced, edema progressed. That is exactly what we will be seeing in most of these children who come with nephrotic syndrome with a diarrheal illness. And always remember, already a hypovolemic state. On the top of that, if there is a loose stool and vomiting is there, that actually push the child further into a hypovolemic shock, and even acute kidney injury can occur. And this also can be a precipitating factor for thrombotic episodes. So multiple complications can come up once this nephrotic child in active nephrotic state develops a loose stool, vomiting and all, or any other source of fluid loss is there. That is actually a detrimental thing that any child with nephrotic syndrome who is in relapse. So that all these things are happening to this child. But my question now is, the loose stools are reducing, the fluid that is being lost, that is getting controlled. Child was treated with IV fluids and IV medications, and edema is progressing. What is the reason?
Madam, the fluid maybe have shifted to the extravascular compartment.
Okay,
due
good.
to the hyperalbuminemia.
Yeah, so the proteinuria is continuing. Child is in active nephrotic state, and whatever fluid that you give, especially the what is the fluid that is given for resuscitation usually?
Normal saline.
We give normal saline. Okay, so the normal saline that we give will be shifting to the interstitium rather than remaining in the intravascular compartment. That exactly is the reason why we prefer to give IV albumin. Okay, so if a child with nephrotic syndrome is coming and in shock after your initial fluid bolus, it is prudent to give IV albumin so that whatever albumin you give, it is going to remain in the intravascular compartment for some time. Yeah, till the kidneys are filtering it out and you are losing that albumin in urine. Okay, Ria, shall we proceed further? Is there any problem that is to be cleared now? Have you understood? Have you all postgraduate students understood the situation that we are facing now? Can we move forward? If anybody is having any doubt or anything, the reactions, you can have the raise your hand option so that we will address that. Okay, so shall we proceed? Okay, Ria, continue.
So coming to the past history, the child had her first episode of nephrotic syndrome, diagnosed at 2 years of age. That was in Jan 2022. And she was started on daily steroid at 2 milligram per kg per day, which was continued for 6 weeks, and alternate day steroids at 1.5 milligram per kg per day for 6 weeks, and then tapered and stopped.
Okay, so what do you think this child is having? With whatever history in the initial episode, what is your impression on this child's nephrotic syndrome?
It has occurred at the typical age group.
2 to 6 years of age. Okay. Okay.
It's probably an idiopathic type.
Probably
an idiopathic type.
Okay, but you are telling that first episode of nephrotic syndrome was diagnosed at 2 years of age. You are not telling us that whether there was hematuria, hypertension, whether there was extrarenal some manifestation like rash. All those negative things are not presented here. Here, whatever information you have given, you just say what is the inference. What are the positive things that we are having with this child at this point? She is a steroid
sensitive.
Sensitive. She is a steroid responder. So that is a very important point that we have to consider. That is the positive point that we have to underline. She is a steroid responder. But I would be interested in knowing, after starting steroid at 2 milligram per kilogram per day, on what day she responded. On what day the urine protein became or remission was attained, on which day of starting the illness. So that is very important. In what way this is important? Can you tell us?
If the remission is attained after 2 weeks, and if the remission after starting the initial steroid is occurring late, there's more chance that the child would go into a frequently relapsing or a steroid.
No. Be slow. Tell that once again.
If the remission has occurred later,
okay,
it has taken more time for remission to occur on starting daily steroids, there is more chance of the child later relapsing and going in.
Certain definitions are important at this point. This child, if the child is responding within the first 2 weeks of, let us be positive and take the positive things first, rather than going not responding beyond 2 weeks. So let us say the child is responsive within first 2 weeks of illness. No hypertension, hematuria, or acute kidney injury during this episode. Then the long-term outcome is possibly going to be better for this child. We have to understand that all children with nephrotic syndrome is a disease of relapses. So very few percentage of children will have one episode and then a lasting remission and no other relapses. Almost all children will have multiple relapses, and some of them become frequent relapses, some of them become steroid dependent, some of them go for late steroid resistance. So all these terms which I am using now are to be defined, that we will do later. So this child is a responder, is a good news. Okay, but at what point this child responded is something that we have to look at this point. Okay. Then the second good thing is, we could, after giving the 6 + 6 weeks of steroid, that she has received is also a good point. She has received the guideline-based treatment. And then the steroid was tapered and stopped. And so we could stop the steroid and she maintained remission of steroid for some time is also a good news. So many good news is there for this child. That is the typical age of onset. Hypertension, hematuria, AKI, you have not said, we will have to look at that. Then she responded, but we don't know at what day of illness after starting treatment she responded, and we could stop the steroid. And I would like to stress that whatever the graphical representation of the relapses and treatment response that you have shown here, this is absolutely great. I think each and every one of us should be drawing something like this in the case sheet whenever we see a nephrotic child. This gives a very great idea regarding what exactly is happening. That is 2 mg/kg, then coming down to 1.5 mg/kg, then tapering and stopping. All that is represented in a very nice manner. Congratulations on that. So let us now move forward, and I want you to give us some idea regarding whether there was atypical features in the first episode, as well as on which day of illness the child responded. Can you say that? Okay.
Yes. In the first episode, there was no history of any hypertension or hematuria. And
okay.
the mother doesn't exactly remember when the child had gone into remission.
Okay, so for that, actually, when we see the first episode in any child, we should be having the urine albumin chart with us. What is response or what is remission? Can you define remission?
Remission is urine albumin nil or trace on 3 consecutive days, early morning samples, or urine PC ratio less than 0.2 mg/ml.
Okay, and child is?
Edema has reduced.
Yeah, edema is almost free of edema. But edema free may not be a point in the definition. In the definition only we have urine protein nil or trace for 3 consecutive early morning sample. Okay. And yes. So this child had responded. So if you are having the urine albumin chart with us, we will be able to understand. And when you are discharging, you have to put that also as a point. The child responded on such and such day of illness. That is usually after starting steroid, if the response occurs within the first 10 days. See, the literature is telling early response definition is 2 weeks, but many studies have shown that the response occurring within the first 10 days is going to be a very prompt response, and the outcome is going to be, the long-term prognosis is going to be good. Okay, continue.
So she had her first relapse in June 2022 that occurred after 1.5 months of stopping steroids, and it was triggered by an upper respiratory infection. It required hospital admission, and the child was treated with daily steroids at 2 mg/kg per day for 2 weeks, followed by alternate day steroid at 1.5 mg/kg per day for 4 weeks, and then tapered. And at that time, BP was found to be high, for which a tablet was started. And her second relapse occurred in August 2022, when the child was taking alternate day steroids at 0.75 mg/kg per day and required ICU admission for severe pneumonia. And the child was treated with IV antibiotics, albumin infusions, and took daily steroids at 2 mg/kg per day for total 2 weeks, followed by alternate day steroids at 1.5 mg/kg per day for 4 weeks, and which was being gradually tapered as being depicted in that line diagram. When
okay, so you stop here, you go to the previous slide. Yeah, okay. So now we are having this child going through that course of nephrotic syndrome. So what is your impression on the first relapse? First relapse occurred 1.5 months of stopping steroid. It was triggered by a URI. So what is the inference? 1.5 months of stopping steroid, the child relapsed. What is the inference?
That is the frequent relapse.
No, it is not frequent relapse. Frequent relapse definition is totally different. So if a child is having a sustained remission for at least 6 months of stopping the steroid in the first episode, that child is going to be most probably an infrequent relapser. You understand? So if you are telling that the first relapse occurred after 6 months of stopping steroids, then the prognosis would have been better for this child. The onset of the illness is at 2 years. That actually makes the child at the cusp of an atypical onset. Even though 2 to 6 years is the time that we will be telling, we have to have the date of birth of this child and the month of relapse, month of the first episode, to see whether it occurred just prior to the second birth. Anything occurring before 2 years is going to be a longer illness. The longer trajectory with multiple relapses is usually the rule. Okay, so this child relapsed within 1.5 months of stopping steroid is a negative point for the child, that the course that is this child is going to follow in future is going to be more frequent relapses, dependence, or things like that can come up. And then it is triggered by URI. So why URI is precipitating a relapse? What is the relationship between nephrotic syndrome and infections, especially viral infections? Why children with nephrotic syndrome relapse following infections? Gauri can give the answer. Can you show your face?
Child is having
can you
immunomodulation occurs during the
video on cheyamo.
Madam?
Yeah.
Immunomodulation.
Immunomodulation. That is a very broad term. What happens when some infection occurs? What happens? What happens?
Immune response should have.
What immune response? What immune response? What is the immune response that occurs? Who gets activated? Who are all coming to the T cells and B cells? Okay, so who is the culprit here? Which cell?
T cells.
So it is a
suppressed in the nephrotic syndrome.
T cell mediated response is happening. So what is happening? What is the T cell producing?
Interleukin.
What are the factors that the cell used to communicate with each other? What is that factor that the cell is producing for communication between the cells, between each other? What is that factor?
Complement activation, complements.
No.
Right.
No. Cell talking, cell communication.
Cytokines.
The chemicals, cytokines. So the cytokines are produced. What is the relationship between cytokine and the kidney? How this infection is triggering the relapse? We are always telling, this nephrotic syndrome, is it an immunological disease or a kidney disease? I am talking about the idiopathic one. Minimal change. It is an immune-mediated disease, which is actually affecting the kidney, is the target organ. But there are other nephrotic syndromes where you will have the glomerular filtration barrier being affected because of some lack of protein that is there or some injury that is happening. There can be proteinuria. That is different. But idiopathic nephrotic syndrome, which is actually the first episode, as well as the relapses, can be triggered by infection, because the cytokines will go and what will they do? They will affect which barrier is affected. Why there is massive proteinuria? You will be having a lot of protein that is being lost. Nephrin and podosol proteins that are there in the glomerular filtration barrier. So if these nephrin and podosol are all injured, or it is absent, or it is destroyed, you say that there is a structural damage to the podocyte and the glomerular filtration barrier. Whereas in minimal change disease, you will see that light microscopy and immunofluorescence is actually showing totally normal situation. There is no structural damage. There is the structural integrity is maintained. But there is some problem. Protein is being lost in large amounts. This is because of the charge selective barrier that is being affected by the cytokines. Charge selective barrier is made up of the sialoglycoproteins or glycosaminoglycans like heparan sulfate, which are present on the GBM. That is the charge selective barrier, which is actually getting stripped or removed by the cytokines. So once it is removed like that, then all the proteins are going to be going out of the filtration barrier. Because you have to understand that the ultimate filtration barrier is the filtration slit, which is the size of which is 4 nanometers. Whereas the albumin molecule is 3.6 nanometers and it is negatively charged. And so this negative charged glycosaminoglycan is actually acting as an electrical wire, which is actually repelling the albumin and not allowing the albumin to reach even near the filtration barrier. But once you have got the infection, the cytokines are coming there and it is interacting with this charge selective barrier and destroying it. The albumin molecules will be, and albumin-like molecules like transferrin, vitamin D binding globulin, they are having a free run through this 4 nanometer filtration slit pore. Okay. So that slit pore is actually guarded by the nephrin, podosin, alpha actinin, or such molecules. So once that is damaged, actually there is a structural damage to the filtration barrier. So those types of nephrotic syndrome where there is a genetic background is not mediated by this immunologic event. So here this child is having an infection which was triggering a relapse, which is again telling you that this is an idiopathic, possible minimal change disease only. Okay, so the child is again responding to steroid. But one negative point that is there is this time what was there? High blood pressure requiring tablets, requiring medication. Okay, so that is one point that we have to. And in the next relapse, again, there is more difficult situations that are coming up. What are they? What are the difficult situations for this child in the next second relapse, Ria?
Severe pneumonia.
Severe pneumonia requiring
ICU admission.
Yeah, severe pneumonia requiring an ICU admission is making her more complicated disease that will be there in the subsequent relapses also. So this is actually a severe relapse. Once an ICU requiring admission is there due to any problem, then the child is having a more severe, serious illness that we have to consider. And then what is happening? So how many relapses? So let us see. The onset of the disease is Jan 2022 and June, August. So how many episodes in all this year? Let us see the rest of it. August 2022 we have reached. So is she a frequent relapser? That is what we have to think now. And you can see from the chart, you can see that from this point onwards, from June 2022 onwards, the child is never off steroids. So that is also an important point to be noted. So let us proceed further.
So the third relapse occurred in October 2022 when the child was taking alternate day steroids at 0.75 milligram per kg per day for her second relapse. And that was triggered by an urinary tract infection. The child was given daily steroids at 2 milligram per kg per day for 2 weeks, after which she achieved remission, followed by alternate day steroid at 1.5 milligram per kg per day for 2 weeks. And then the child developed fourth relapse. That is in November 2022, for which daily steroids were started.
No. This she was on 1.5 milligram per kilogram. And at that point, while on 1.5 milligram per kilogram, she is relapsing.
Yes.
So what was the trigger factor for that relapse in November 2022?
She did not have any trigger identified.
She did not have any trigger, but just relapse. So my question is whether she responded at all. See, she is having you are telling that your blanket statements are being made like given daily steroids at 2 milligram per kilogram for 2 weeks, followed by alternate day for 1.5 for 2 weeks. So I'm not sure whether the child was really in remission or not. Because it is very unusual unless the child is in a not in remission, that relapses are occurring every month like this. So how will you assess for remission? So here in October, the child had a relapse, and November, December, Jan, you can see that just coming down after 2 weeks, every 2 weeks you're trying to come down to 1.5 milligram. So whether we are coming down to that level without a proper remission that is being attained. So how will you assess for that? Because the initial episode you could stop the steroid, next episode you could come down to a very lower dose and she is relapsing, and then the next episode it is 0.75, that is also reasonable, but subsequent episodes are at 1.5 milligram per kilogram per day and she is having relapses. And was all these relapses associated with edema? Did the albumin normalize in between? Did the cholesterol come down in between? Was the child's PC ratio tested? Urine albumin periodically assessed? Without that, I will definitely think of the October relapse which is going on till December. Why do you say that you are giving for 2 weeks and then followed by alternate day for 2 weeks or 4 weeks? So even though that is the guideline that is mentioned, why do we want to keep it at 2 weeks? Because 80 to 85% of children with steroid responsive nephrotic syndrome are going to achieve remission with 2 weeks, within 2 weeks of daily steroid therapy. So that is why we say it is give for 2 weeks and then you ask them to review. But at 2 weeks, you have to assess whether this child is already in remission, as you have already defined, like urine protein nil or trace for 3 consecutive days, early morning sample, or the PC ratio is less than 0.2. You have to check without documenting, just by thinking that 2 weeks is enough and shifting. The child may be in partial remission. Child may not have attained full remission. So that documentation is not there. Can you tell us in depth what exactly is happening at this after October 2022?
Yes.
Are there any documents of complete remission that is there in between?
Yes. Yes.
So whether it was
after taking daily steroids for the third relapse for 2 weeks.
So what was the trend? So don't tell me that on day 14 everything became okay. On which day the urine became nil? You understand? Yes, what all things you have to see in such kids.
Yes.
So daily they have to check the urine protein and document it in their nephrotic diary and bring it to you when the child is coming for to the hospital for checkup, and check the urine PC ratio, check the serum albumin. The cholesterol may take time to come down. It may not become normal, but the serum albumin will be improving and possibly it will be near 3 milligram. And then PC ratio will be nil or less than 0.2. Such documentation is important, especially a child who is having frequent relapses like this, who is coming for follow-up. Yes. So that is not there in this history presentation. Okay, and then what else we have to think of? The child who was having a reasonable optimum course till now is presenting like this. What else we have to think of? We have to think of what is the most important cause of remission not getting sustained? What is the most important cause? It is non-compliance. It is non-compliance. You're sending the child home, child on a regular long-term medication. The parents may not be very happy to give it in the way that you are telling, or they may be actually not giving the drug properly. So non-compliance is one of the most important cause of multiple relapses, and you have to look at that. And you are looking for steroid side effects. Okay, continue.
The child had so ophthalmology evaluation was done for the child, and that was found to be normal. And during these first episodes or the subsequent lapses, she had no history of any tuberculosis or any contact with tuberculosis positive patients, or any history of other infections other than mentioned. No history of any blood transfusions or jaundice. No history of any rashes or joint pain or bone pain. No history of any allergies or asthma.
So why do you want to take all these histories?
To look for any secondary causes of nephrotic syndrome.
Do you think tuberculosis is a secondary cause for nephrotic syndrome?
No, madam, that.
Or you are taking tuberculosis history for some other thing? A 3-year-old child.
Since she's
blood transfusion. Why do you want to take the history of blood transfusions?
Hepatitis B, HIV.
Will produce nephrotic syndrome at this fast?
Not this fast.
So see, take negative histories pertaining to the problem rather than just being blanket about negative histories. Significant. See, you are in the PG level. If you are a UG, no problem. You can say all these things and get away with it, but not for the post-graduation. Blood transfusions, we know that HCV, hepatitis B, all can produce nephrotic syndrome, that is glomerulonephritis, and membranous nephropathy, HPV for membranous. But in children, usually it is hepatitis B is not through blood transfusions that you will be getting, no, unless it is a TAL child requiring recurrent blood. So blood transfusion history at this point is and jaundice. Why do you want to talk about jaundice? Why do you want to talk about jaundice?
But hepatitis B itself.
Thinking about hepatitis B itself. Okay. Okay, then rash, joint pain, bone pain. Tell me what is the link?
Rashes, HSP.
HSP, okay, then.
Joint pain at this age, not sure for me. Or SLE.
SLE, yeah, SLE. Bone pain.
For any malignancies, hematological malignancies like leukemia.
So in this past history, actually the talking about the collagen vascular disease is fine. Okay. Yes. And this long history, if it is a leukemia, lymphoreticular malignancy, the child would have been getting that diagnosis and treatment much before this, no?
Yes.
Okay. Yes. Okay. What is the implication of allergy and asthma? That is important. That should have come first. What is the implication for allergy, asthma, and nephrotic syndrome, idiopathic?
Idiopathic nephrotic syndrome may be associated with allergies.
So we have made a statement before that the idiopathic nephrotic syndrome is an immunologically mediated disease. So now I will put forth the question: what are the evidences to suggest that this MCD, idiopathic minimal change disease, is an immunologically mediated problem? Chinnu can answer. Give me 1, 2, 3, 4 multiple points to say that it is. Where is Chinnu?
Madam.
Please on the video so that we can see you. Yeah.
Minimal change disease actually responding to steroid treatment.
Good.
It is an
okay. So it is immunosuppressants producing a remission for the nephrotic syndrome. So that is point 1. Okay. Then already 1 point we have already discussed. What was that? Already 1 point which we have discussed, talking about the signs and so infections being trigger for relapses. Infection triggering a relapse. Okay, so infection triggering a relapse, immunosuppressants being used for the treatment, then association with this point that we are discussing now.
Allergies.
Allergy, atopy, asthma, hay fever. So all those immunological events are having an association with childhood nephrotic syndrome. And children with nephrotic syndrome, they may be having asthma, or their siblings may be having such problem. There may be a family history also. So that is another point. Then there's 3 points we have completed. Fourth point, that it is an immunologically mediated disease. What is the type of nephrotic syndrome that we see in lymphomas? B-cell lymphoma. Lymphoma MCD. Minimal change disease. Then there are some HLA associations that are there. So all these points are pointing to the fact that nephrotic syndrome is an immunologically mediated disease. We are talking about idiopathic minimal change nephrotic syndrome. Okay, continue. Continue, Ria.
Yes, ma'am. Coming to the antenatal history, the child is the second child of non-consanguineous marriage.
So anything significant? Any point that is significant?
Antenatal USG detected an oligohydramnios.
So this child, so this child is having a history of oligohydramnios in the antenatal period. Okay, that is good. Okay, that is an important history that is there. And if the child, then I will be interested in knowing the birth weight of this child. What is the birth weight of this child?
2.6 kg.
2.6 kg. And then I will be interested in whether the child passed urine on the day 1.
Yes.
Okay. So that also is okay. And the birth weight is, if it was only 2.3 kg, what is the implication? Birth weight is less than 2.5 kg. Is there any implication for the nephrotic syndrome cause?
There's more chance that the child will go into a frequent relapse.
So, okay, so SGAs are having more chances of having frequent relapses and steroid dependence. So what is the change that is occurring in the kidney in a small for gestational age baby? When the baby is SGA and there is history of oligoamnios, what should come to your mind? Oh, this baby is having such an issue. So something should be problematic in the kidney as well. So what is that problem that can be there in the kidney? There can be reduced number of glomeruli. Nephron reduction can be there. The total number of nephrons may get reduced. So that is oligonephronia. So, okay. And Potter sequence, somebody is putting that Potter sequence is actually, it is almost a fetal ESRD syndrome. That is, both the kidneys are not working at all in the newborn, in the fetus. So producing no urine. So severe oligohydramnios and the oligohydramnios sequence. And such babies are usually presenting with pulmonary hypoplasia. And if in the severe form, the life may not be sustainable. Okay, so that is not, Potter is not having such existence so as to develop nephrotic syndrome and all. So this, any child, you should be taking the history of an SGA, birth weight. Birth weight is important. Okay, continue.
Development history, all the development.
Okay, so all the developmental milestones are achieved in the normal manner. And the baby is fine. Usually what we see is all these children with nephrotic syndrome and almost all the renal diseases, they are all having a very good developmental milestone and good brain. Okay, and then vision and hearing is normal. Is there any implication for vision, hearing,
Vision
and kidney? And the kidney. So we are talking about the genetic nephrotic syndromes. Can have associated other systemic manifestations, visual defect, microchoria, hearing impairment, Alport syndrome. Yeah. So such history as well as family history of vision and hearing is also important. Okay, continue. Okay, child is on a restricted salt intake as she is hypertensive. You said that the child was hypertensive in the second relapse or first relapse. But was she continued on antihypertensive medications, or she could be off medications after she attained remission?
No, madam. She continues to be
hypertensive. Okay, continue.
She had a total intake of 820 kilocalorie over a required of 1010 with a deficit of 190, and a protein intake of 25 over a required of 28 with a deficit of 3.
Okay. Okay. So she is immunized for age. Which are the vaccines that we will be really looking at when we see the immunization history? Which are the vaccines that are important for a nephrotic child? All vaccines are important, but there are certain special vaccines that we should be looking at when we see a child with nephrotic syndrome. So what are those vaccines? And is the child vaccinated for all that?
Pneumococcal vaccine?
Yeah, pneumococcal vaccine.
Varicella vaccine?
Vaccine. Influenza vaccine not taken. And hepatitis B. Hepatitis B is taken, no?
Yes,
it is coming. Okay, so hepatitis B is also important because we never know. Children with nephrotic syndrome may in the future, if they develop a renal failure for some reason and requires a transplant, the child will have to be hepatitis B and dialysis and all. So these are the vaccines which we are actually interested in. Why varicella vaccine?
Since the child is already immunosuppressed.
Yeah. So if the child develops a varicella, the going to be a very severe form of varicella. Okay, continue.
Family history. There is no history of.
Okay, continue.
Socioeconomic history. Four-membered family. The child belongs to upper lower class according to modified Kukusami socioeconomic scale. Father, he studied up to 10th standard, worked as a mechanic. Mother studied up to diploma and she's a home.
Okay. So total monthly income of 5,000. Do you think somebody can live in Kerala with a total monthly income of 5,000? It is practically not possible. No, be practical when you present. Okay. And you are telling that upper lower class. And your monthly income that is presented is not sufficient for even one person in this particular situation in Kerala. Okay, continue.
Coming to the general examination, the child was active and alert at examination. Periorbital and bilateral pitching pedal edema was present. No pallor.
So you're telling there is bilateral pitching pedal edema.
Yes.
What is the pattern of edema in nephrotic syndrome as compared to glomerulonephritis? Is there any difference in you have seen multiple children who are having nephrotic syndrome? You have seen many kids who are having acute glomerulonephritis, AGN, we call IRGN now. Okay, so what is the difference between the pattern of edema in these two diseases?
Nephrotic syndrome usually a mild edema.
Nephrotic syndrome is mild edema. Severe renal failure, if it is there, child is presenting with anuria. Severe AK.
Interesting.
So is there any clinical difference between the nephrotic edema and the glomerulonephritis edema? What is the reason for edema in glomerulonephritis? What is the reason for edema in acute glomerulonephritis? Why they become edematous? And why nephrotic child becomes edematous? So that pathogenesis of edema is totally different in these two clinical situations. Okay, so that will explain the difference between the edema. And clinically, it is very important for you to distinguish between the two. If you are seeing a child for the first time and you can make a diagnosis that without seeing the blood investigations, this could be nephrotic, this could be nephritis. So who is going to answer? Rahul? Only 5 PGs are there in Kottayam. Other PGs from other colleges are also there. They can be volunteers for answering. They can raise their hands in the reactions. There is a reaction which can be in that lower part. You can see that. You can raise your hand. Raise your hand and please answer. Anybody? If Kottayam students want to keep mum, Kottayam students, who is going to answer?
Or else they can use
Gauri.
the chat box also, madam.
Yeah, they can. I don't know, because faculty I should not be calling for. So Ahmad Musa, pitting pedal edema in nephrotic syndrome, ankle edema in glomerulonephritis. Ankle edema won't occur in nephrotic syndrome. So be fast. Let us move forward. The time is actually moving very fast. So what is the pathogenesis of nephrotic edema? Nephrotic edema is hypoproteinemia, and we talk about the underfill hypothesis, overfill hypothesis. So it is hypoproteinemia, and fluid is seeping into the interstitium. So it is basically an interstitial edema. Okay. Whereas in acute glomerulonephritis, it is secondary to salt and water retention that is there. Okay, so it is a fluid overload edema, whereas here it is a fluid is high, but it is not in the vasculatory. Okay, and so it is a soft pitting edema in nephrotic syndrome. It is very soft. It is like if you press your finger will just go in if the child is having nephrotic syndrome. Whereas in glomerulonephritis, you have to really apply pressure. It is a hard pitting edema due to secondary to fluid retention, and usually there will be associated smiling umbilicus, abdominal wall edema. Parietal wall edema is more seen in acute glomerulonephritis, whereas ascites genital edema is more in nephrotic syndrome. And then the earlobe sign is also important. Have you ever looked for the earlobe sign? You have to actually catch hold of the earlobe of the child and try to flex it. And the cartilage collagen is gone in the nephrotic child. So it will be very pliable and soft. It is very soft. Tomorrow you go back and try to flex the ear cartilage of children with nephrotic syndrome and children with glomerulonephritis. In glomerulonephritis, the firmness of the ear cartilage is preserved, whereas in nephritis, that it is very soft and pliable. I'm not talking about edema differentiation, but at another sign that may help you. Then nephritic child is usually hypertensive, whereas nephrotic child is usually having BP that is normal usually, but there can be hypertension in MCD in almost 15 to 20% of cases can have hypertension, but usually they are mostly normotensive, or sometimes the BP may be on the lower side, especially if they are underfilled. So these are certain signs which will help you to differentiate between a nephrotic syndrome and a nephritis in the ward. Okay. So let us now move forward further. You can start presenting further.
So the pulse rate was 110 per minute over the right radial artery. Normal rhythm, volume, character, no radiofemoral or radial delay. And all the peripheral pulses were felt equally and bilaterally. BP 98/56 millimeters mercury in the right upper arm in supine position.
So do you think this pulse rate of 110 is okay for this child? 110 pulse rate with a blood pressure of 98/56 between the 50th and 90th percentile, 56 diastolic. CFT was capillary refill time was less than 2 seconds. Okay. Okay. So what was the handshake of this child like? Did you shake hands with this child?
Yes.
Was it a warm handshake or a cold handshake? It was warm. So if the child is having an underfilled situation, you may get a cold extremity as well. Okay. So underfilling is associated with tachycardia, cold peripheries, BP that is actually on the lower side. And if a big child is there, you can check for the postural BP fall, postural hypotension. So those also are important signs that you have to look when you are examining a nephrotic child. Go further. Go ahead.
Head to foot examination. The head was normal in size and shape. She was having moving pace, Eyes were normal, ears normal, oral cavity normal, buffalo hump was present, chest was normal, abdomen was distended with smiling umbilicus, no dilated veins or spiral. External genitalia was normal, no vulvar edema, no rash, hair and nail.
Normal. Okay, continue. Go further.
Anthropometry, weight with edema was 13 kg over an expected of 13.8 kg, which is between 0 and -2 standard deviation. The child's weight before admission was 11 kg.
So don't you be calculating the parameters based on the pre-morbid weight rather than the edema weight? So 11 kg would have been the obtained weight, 13 kg. You can write dry weight 11 kg.
Yes.
Okay, and then based on the dry weight, you have to make the assessment. Always remember. Okay, don't take the wet weight for one thing for parameter assessment, second thing for anthropometry, second thing for calculation of drugs.
Yes.
The drug calculation also should be based on dry weight and not the wet weight. Okay, go further.
Height 87 centimeters over an expected of 95 centimeters between -2 and -3 standard deviation. She was stunted. Weight for height 13 kg over an expected of 12 kg between +1 and +2 standard deviation. No wasting. BMI 17.1 over an expected of 15.4 between +1 and +2 standard deviation. She is overweight.
So calculating the BMI also you used wet weight or dry weight?
Dry weight.
Okay. Okay.
Head circumference, there was no microcephaly. Mid-arm circumference was normal, and upper segment lower segment ratio was also normal.
Mid-arm circumference also, the presence of edema is going to be a factor that makes it unreliable. Okay, so anthropometry, I would be asking you yet another question regarding this child. What is the height velocity over the last 1 year? That is very, very important. So the height velocity that is lost is also a point that will make you decide on a second line agent. You understand, already you have presented this child as having Cushingoid features.
Yes.
Most important steroid side effect that you have to consider in a child, growing child, is the height velocity. We usually don't pay attention to that. Okay,
yes,
continue.
Coming to the system examination, GIT. Examination of upper GIT, oral cavity was normal. Examination of the abdomen. On inspection, the abdomen was distended with flank skull, smiling umbilicus. All quadrants move equally with respiration. No dilated veins, stars, or visible peristalsis. Hernial orifices were normal. External genitalia was normal. On palpation, abdomen was soft, non-tender, no organomegaly, no fluid thrill, no renal angle tenderness, no masses were palpable. Abdominal girth was 52 centimeters. On percussion, liver span was 5.5 centimeter. The shifting dullness was present. Throb space was resonant. On auscultation, bowel sounds were heard, with no bruit or hum.
Okay. Respiratory system is normal. Other systems are normal. Okay.
Cardiovascular system is also normal.
Okay. Okay. So this general physical examination, were there any striae? What over the abdomen? Striae? There were no striae. There were no striae. Okay. And was there any telangiectasia?
No.
No telangiectasia. So these points also you should be mentioning. So Ria, can you tell me what are the steroid side effects that you will be expecting in a child who is on a high dose of steroid for such a long time? What all steroid side effects? So that is exactly what is important in deciding on the further treatment of this child who is a steroid responder. So you are having a child who is a steroid responder. So your aim is to, the aim in treating any nephrotic child is to maintain remission, to induce remission, to maintain remission. For this child, you can induce remission with steroid, but whether we should continue steroid or whether we should go further in giving another drug. So for that, we have to discuss whether this child is having the side effects of the drug that you are using. So tell me, rattle out all the steroid side effects.
Short stature, obesity, cataract, glaucoma, it can cause osteonecrosis, osteopenia, psychosis, myopathy, gastritis.
Have you checked for myopathy in this child?
Yes, ma'am.
So but you never presented. So any child, the disease per se, the system examination, everything is important. After that, you have to look at whether there are side effects. So how will you assess for myopathy?
Look for the muscle power.
Which group of muscles are affected with steroid? Proximal myopathy. So how will you test for proximal myopathy in a small child, 3 years?
Raising the arms. For upper limb examination, raising the arms, lower limb, squatting, and whether she's able to raise from squatting position.
Get up from the squatting position. Did you check that?
She was able to do that.
So specifically, whether you have checked it, so and presented that there is no evidence of and climbing stairs. Climbing stairs, some children will be. You have already presented this child is having moon face. You have presented. Then you have said that there is buffalo hump. And also you were telling that this child is stunted.
Yes.
But you haven't presented the growth velocity in the last 1 year or last 6 months. You haven't presented. You didn't say anything about the striae. You didn't say anything about the telangiectasium.
Yes.
Okay. So what are the other side effects of steroid? HP axis suppression, increased risk of infections.
Yes.
So what are the bone side effects? You said osteonecrosis.
Osteopenia, slipped upper femoral epiphysis.
Slipped upper capital femoral epiphysis, then fractures. Okay, then what else can occur in the hip?
Hip.
What else? Something with the femoral osteonecrosis, can it happen there? Okay, then what else? What will happen to the spine?
Compression fracture.
Compression fractures of the spine can occur. So the steroid, sometimes if you are just going on and on with steroids, it can be sometimes really, it can produce devastating effect. What in the brain? Can it produce pseudotumor cerebri? Pseudotumor cerebri. So they may come with severe headache. Okay. So multiple side effects can be there with steroid. But what is the benefit of steroid? Steroid is the drug that is time-tested molecule, long duration. We have experience with steroid. We know what are the side effects of steroid. And also this is the drug that is supposed to be inducing maximum remission, in childhood nephrotic syndrome. The problem is this child also we can induce remission, but you cannot sustain remission. So to sustain remission, possibly we will have to rely on other drugs. But even when on calcineurin inhibitor attack and cyclosporin and all, if a relapse occurs, still we go back to steroid to induce a remission. So that is the advantage of steroid. So let us now move further with the investigations. Before that, let us summarize and make a diagnosis.
This is a 3-year-old girl, known case of nephrotic syndrome, with history of 3 consecutive relapses on tapering steroids.
So that requires tapering on high dose. But this 3 consecutive relapses, I am not very sure whether there was a remission in between, because such occurring every month, non-compliance, not attain remission in between, all these are possibilities which are to be addressed as well. Okay. So there is a high dose of steroid that is required to maintain remission. That is what we are assuming now. 2 mg/kg is keeping her in remission. The moment you come down to 1.5, she is relapsing. If I have to believe completely what you are presenting is right. Okay.
Yes.
Okay, then.
And that is associated with an acute diarrheal disease. Probably
that is in the first time, no? That is now she is presenting with shock. Okay.
And on examination, child had bilateral periorbital edema, pitting pedal edema, and the hypertension is controlled on medication. And she was found to be short, overweight, with steroid patients. And system examination revealed distended abdomen with shifting dullness, no evidence of pleural effusion.
Why do you want to specifically say there is no evidence of pleural effusion? When you are summarizing, no evidence of pleural effusion, is it having some impact on your subsequent diagnosis? So don't put such, is it important? And most often there will be some pleural effusion that is there whenever there is this much amount of ascites is there. Clinically, you may not pick up, but sonologically it may be there. So don't say things that are not there. Mostly say things that are there.
Yes.
If you will be putting negative things, if that is having some implication on the diagnosis or management.
Yes.
No implication here. Okay. Okay. So the diagnosis is?
So it is probably a case of high dose steroid dependent nephrotic syndrome.
Why do you say she is steroid dependent?
Because she has had 4 relapses on alternate day steroids while on tapering steroids.
While on tapering steroids. So what is high dose dependence? So you have put it as high dose steroid dependent nephrotic syndrome. Define high dose dependence.
More than 1 milligram per kg per day.
Yeah, anything requiring to maintain remission, threshold doses more than 1 milligram per kilogram on alternate day. So such 2 episodes, consecutive such 2 episodes are there. So this child is definitely a high dose steroid dependent nephrotic syndrome, and she is now in the 5th relapse. Okay, which is complicated by there should come 5th relapse is complicated by
a hypovolemic shock, probably due to the acute diarrheal disease.
But you are not putting it as sepsis. High grade fever, foul smelling stool, requiring IV antibiotics. She was septic, no?
Yes.
Yeah, a 3-year-old child coming with a foul smelling stool and this very high grade fever. Will you be withholding antibiotic thinking that it is viral?
No.
Okay, so it is an acute bacterial sepsis with acute diarrheal disease, possibly bacterial sepsis with shock. Shock can be due to multiple factors. It can be associated, means hypovolemia is there, which is compounded, nephrotic state compounded by the losing through stool as well as the vomitus. She was having vomiting as well. And the sepsis part is also there. So all contributing together will be the shock. So that is making her a complicated relapse. This is a complicated relapse. Okay, and also there is one more complicated relapse that happened before, no?
She had severe pneumonia.
Yeah, pneumonia requiring an ICU care. That is also an important pointer towards a complicated course this child may be having. Okay, so then features of steroid toxicity should come after that.
Yes.
Why you have to put no clinical evidence of spontaneous bacterial peritonitis? When you are giving a diagnosis, give a diagnosis of what is there. So if you are presenting some cardiac failure, then some complication of infective endocarditis is not there and all is okay. But here already hypovolemic shock and sepsis is there. And SBP, what are the clinical features of SBP? This child still may be having spontaneous bacterial peritonitis. If you tap and see the fluid for cells and all, it may be there. But what are the clinical evidences of SBP? Since you have put it like that, let us discuss that.
Severe abdominal pain. Redness over the abdomen.
So that will make the room for another question. What are the causes of severe abdominal pain in nephrotic syndrome? We will come to that later. So severe abdominal pain doesn't equate to SBP in a nephrotic child. What are the definite evidences of SBP? By looking at this child, you can say that this could be SBP.
Redness over the...
Yeah, redness over the
abdomen.
Flanks, redness around the umbilicus. Okay, very high grade fevers, severe abdominal tenderness. But usually a child on such high dose steroid, clinical findings may be very subtle Abdominal pain may not be there at all, but massive ascites may be there. Without ascites, if the child is not having ascites, don't consider the diagnosis of SBP at all. Okay, so
Okay.
no clinical evidence of SBP also, I will score it out.
Okay.
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 And steroid features of steroid toxicity. And you said that this child is obese.
Yes.
That is not there in the diagnosis. Obesity is not there. You said that this child is having stunting. That is not there in the diagnosis.
Features of steroid toxicity.
That can be anything, no? It is a very broad term, features of steroid toxicity.
Okay.
Okay, so whatever is there, you put it down.
Okay.
Okay.
Yes.
Okay. So anybody else to say something about this diagnosis? Any more discussion? Any of our teachers? Purushothaman sir? Sir?
Susan, that is an excellent discussion. I was enjoying. First of all, congratulations for Ria for that representation. The diagrammatic representation of the overall course was an excellent one. And what she missed in the examination part was the patient's appearance. Is a dysmorphic feature or not? That's more relevant when there is an younger age group presentation, as you said, borderline 2 years. Presentation, there's a possibility of it. And as Susan rightly pointed out, the anthropometry and the calculations, there are limitations of many of these things. The obesity, weight part, meta circumference part, but something is very, very important is the height. That is the most important thing because it is relevant. At the same time, it won't change with the steroids. So height part is very important. And in the examination, steroid toxicity, what PGs should be doing is certain maneuvers. Always make the patient sit and stand. Always make them stand on one foot. We discussed the proximal myopathy. How to make out the complications in one sitting is raise the hand and see the combing of the hair. Stand from the sitting position, stand on one foot. And one very important point in the general examination you should have mentioned is you mentioned the reflex, the importance of the reflex. Most of the situations you get the lower grades of power, proportionate reflex, hyperreflexia. But if you get a higher reflex and upgoing plantar, that is one of the clues that there can be a spinal compression or fracture. So small points. And very important about the BP, Dr. Susan already mentioned, you should always be taking the supine and the standing BP. There's a postural syncope situation because hypovolemia, that's a clue. And very important, always record the upper limb and lower limb BP, especially in an older child, because maybe there is an underlying problem of connective tissue disorders there also. But in this case, less likely, but we may be missing an aortic problem. So upper limb, lower limb, radiofemoral delay, and the BP to be checked always in the lower limb. Thank you, Susan.
Okay, Darlie, anything more to add?
Nothing more to add, Susan.
Okay, yeah, Shanavas. Shanavas is there?
Madam.
Shanavas, para.
Okay, every aspects has been discussed.
Yeah, okay.
Nothing more to add, madam.
Okay. Any other senior faculty member who is there in this forum to say some comments, to bring out few more relevant, pertinent points? If there are no other comments, let us now proceed. Okay, Ria, you can continue.
Moving to the investigations.
Okay.
Urine analysis. So urine albumin was 3+, pus cells 5 to 6, RBC 1 to 2, spot 3, PC ratio of 3.7, serum albumin was 1, total cholesterol 520.
Okay, continue.
CBC showed there was evidence of hemoconcentration with HbF 14.8 and a hematocrit of 39.3 and elevated counts 28,620, which is neutrophilic, with a positive CRP 17.8. And the urea was on the higher side, 61. There was hyponatremia, 130.
And a 3-year-old child, 0.9 creatinine, you think it is normal?
That is right.
So you please calculate the eGFR now, all the postgraduate students. What was the height of this child? 87 centimeters. So with 87 centimeters, all the postgraduate students, let us calculate the eGFR of this child, because RIA hasn't marked it as abnormal. So let us see the eGFR. What is the expected eGFR at this point? That is one question. And what is the eGFR now for this child? So what is that formula?
0.415 length divided by serum RIA.
Okay. So just calculate it and say the value. All of you calculate. How much it is? Yeah.
Yes, madam.
How much it is?
40.9.
So you think it is normal?
No, madam.
What is the expected at this age? 3 years.
More than 6.
At what age the GFR of a child becomes that of an adult? Vishnu, tell me at what age the GFR of a child will become that of an adult?
Madam, after 10 years of age.
My goodness. No, so let us see that. Let us keep that. Rahul. Gauri.
By 20 years.
20 years. Chinnu. Huh? Chinnu. What is the GFR at birth? See, at GFR of a newborn baby is 30 plus or minus 15 ml per minute. So that will come to 15 to 45. Such range is there. Okay. Whereas by 2 years, the GFR of the child will become 100. So that is the adult GFR. So by 2 years, the GFR will be 100. That is, it becomes like that of an adult. Okay. So it is not 20 years, it is 2 years. And so this child of 3 years, I would expect the GFR to be 100. Here it is only 40. So this child is in AKI. This child is now in acute kidney injury. The normal creatinine at this age is some 0.4, 0.5, 0.6. Okay. So this 0.9 also you should have just highlighted. You never understand the significance of these numbers of the serum creatinine values unless you start calculating the eGFR in all children who present with kidney diseases. You will miss. So this child is in AKI. So what is the reason for AKI in this child? So one more question that was to be discussed was remaining one, that was, what are the causes of abdominal pain? Abdominal pain in a child with nephrotic syndrome is one question. And the second question is, what are the causes of AKI in a child with acute nephrotic syndrome, acute presentation? So I think Ria can answer the causes of AKI, whereas Gauri and Chinnu can answer the causes of abdominal pain. Okay, so Ria, you can start rattling now. What are the causes of AKI in this particular situation?
Hypovolemia.
Hypovolemia. Okay, I agree. Hypovolemia. So it is pre-renal. It is pre-renal. But remember, pre-renal will produce only an elevation of urea.
Yes.
It will not produce an abnormality in the creat. You agree?
Yes.
So once the creat is also elevated, the pre-renal factor that has progressed to acute tubular injury. So the hypovolemia is the cause of ATN here. So I agree. Hypovolemia, the shock which was there. Okay, agreed. Then
severe infection.
Sepsis. Okay, then causes of AKI in nephrotic syndrome. One by one.
Thrombosis.
Renal vein thrombosis. Very good. Then
interstitial nephritis due to drugs.
Interstitial nephritis, drug-induced interstitial nephritis. Very good. Then, can you tell some drugs that can produce interstitial nephritis in this particular situation?
Calcineurin inhibitors.
We are not using here, no? Once a child became too much edematous, you might have given some drug which can produce, which can compound the hypovolemia. It can precipitate diuretics. So furosemide. Furosemide can precipitate further hypovolemia to acute tubular necrosis, especially in the setting of diarrheal illness. So whenever there is diarrheal illness is there, don't give furosemide. Whenever serum albumin is 1 and urea is showing pre-renal increase, you should not give diuretic without supporting with IV albumin. Okay, so that is an indication for IV albumin. So we have to discuss the indications for IV albumin also. Just keep it with you. Okay, so pre-renal factors progressing to acute tubular necrosis, pre-renal factors compounded by other losses like loose stools, vomiting, then use of diuretics, then shock, sepsis, renal vein thrombosis, drug-induced interstitial nephritis, then further down, other nephrotoxic medications. You have already listed one.
NSAIDs.
Yeah, NSAIDs. Especially if this child was given because of high fever, some doctor has prescribed mefenamic acid, ibuprofen. The child would have been pushed into AKI. Right now also we are having in the ICU one child who was requiring dialysis. The child presented with fever, vomiting, loose stools, was given ibuprofen and then developed severe anuric renal failure and required dialysis. 5-month-old baby. So such things can happen. So you have to be judiciously using the drug. So NSAID, then tell me one more drug which can reduce AKI. You are using some antibiotic. Aminoglycoside. Very good. Okay, aminoglycoside. Then calcineurin inhibitors. If thinking that this child is high dose steroid dependent nephrotic syndrome, before correcting all the pre-renal factors and treating the sepsis, if this child was started on tacrolimus or cyclosporin, you will be producing AKI. So drugs. Then last but not very straightforward cause of AKI in a nephrotic child is nephrotic syndrome. Tell me.
Rapidly progressive lesions.
Yeah, sometimes that can happen if there is an associated. So if the child is having a break in the skin and is developing an infection of the skin, and on the top of that, if there is an infection related GN developing. Okay, but that is a little remote. Usually you won't be seeing, but sometimes you may see. There may be this striae on the abdominal wall breaks, and then that gets secondarily infected, and then the child can develop a post-streptococcal GN. Then it will be a catastrophic situation. Okay, so that is a little far-fetched. So all the causes of AKI we have discussed. So I hope the other group, Gauri, Chinu, ready with causes of abdominal pain in nephrotic syndrome. Will you rattle it out? Chinu or Gauri? Who is the taker? Gauri. Gauri can answer.
Madam, it could be due to SBP, renal vein thrombosis, and mesenteric ischemia.
Okay, so most important and common is
gastritis due to
gastritis, esophagitis, gastritis, peptic ulcer, pancreatitis, all can be produced by steroid. Then you said that the child is coming with severe abdominal pain, not SBP, severe abdominal pain.
Renal vein thrombosis,
Thrombosis,
mesenteric ischemia.
see, in the renal vein thrombosis, SBP, all correct. But the child who is presenting with severe abdominal pain, serum albumin only 1, and you gave an IV albumin, the pain disappeared. So what is the cause? Hypovolemia causing mesenteric ischemia. So that is a very important cause for abdominal pain. We have to remember, child will be in real distress and pain, but once you give an IV albumin, it is something like you are acting like God, relieving all the pain, and the patient will be totally impressed. And the parent also, the child is really happy. So that is an important cause of abdominal pain. The other drug-induced gastritis, esophagitis, then other causes like this acute diarrheal illness, appendicitis, all that can happen, intussusception, all that is there, but more common in nephrotic syndrome. And for nephrotic syndrome is mesenteric ischemia, SBP, and renal vein thrombosis. Okay, so these are the causes for abdominal pain. So what is the next question that to answer? What was that that came up just now, and then we thought we will discuss it later. What was that? Indication for IV albumin. Okay, so when will you give IV albumin? Will you give IV albumin in this child? This child is having a serum albumin of 1, urea of 61, creat of 0.9, reduced urine output, and hemoglobin is 14.8. You're telling that she is hemoconcentrated. What about her sodium? How much is the serum sodium? 130. 130. That is also on the lower side. 130 is actually 130 considered as sodium is on the side. So sodium low in a child like this is because of dilutional hyponatremia. So what are these? So will you give IV albumin in this child?
Yes, after correcting the shock.
For correcting the shock itself, you are giving IV albumin, no? That I already told you. When you give saline bolus, it is not going to remain in the intravascular compartment. So let us look at the you are giving a child with shock 20 cc per kg of normal saline. 10 kg child, you have given 200 ml of normal saline. So in what way it will get distributed? How many compartments are there in the body? You are infusing it into the intravascular compartment. What are the other compartments that are there in our body, in the total body water? What percentage is total body water?
Extravascular.
10 kg child, how much will be the total body water? 1 year, 10 kg, total body water. Who is going to answer? Muhammad Musa. He's a postgraduate student or a faculty or a pediatrician. Ahmad Musa, please introduce yourself. You are right. He's a PG where? Which college? KMCT. Okay, so you are right. 6 kg or 6 liters is the total body water. So how is that total body water distributed? You are having different compartments.
Intravascular,
interstitial, that will form the
extracellular.
It will form the ECF. You have got the ICF also. So what percentage is in the ICF? What percentage is in the ECF? So it will be 40-20. So 4 liters in the ICF, 2 liters in the ECF. So out of the ECF, now you have to divide this 2 liters into the interstitium and the intravascular compartment. So how much is in the interstitium? How much is in the intravascular compartment? 1/4 and 3/4. 1/4 in the intravascular compartment and 3/4 in the interstitium. So We are having 2 liters now. So if 2 liters is divided, 4 will be 500 ml. So you have to understand that a 10 kg child is having only half liter of blood in the body. And you are giving, for correcting the shock, you are giving 20 cc per kg of normal saline. So how will this normal saline will get distributed, and how much fluid will be there in the intravascular compartment? Anybody, any takers for this question? This is a little difficult question. You are giving 200 ml of normal saline. So it will be getting distributed in the ECF alone. It will be getting distributed in the ECF only. But if we are giving 10% glucose, it will go to the total body water, getting distributed in the same proportion as the total body water distribution in ICF and ECF. So if you are giving normal saline, it is getting distributed in the ECF. The percentage distribution will be same as 3/4 in the interstitium and 1/4 in the intravascular compartment. So 200 ml, 1/4 will be 50 ml, and 50 ml is 10% of the total blood volume. So if you are losing 10% of the total blood volume, you are in shock. So by giving 20 cc per kg of normal saline, you are giving 50 ml in the intravascular compartment to replenish that loss so that your blood pressure becomes okay. But for a child with nephrotic syndrome, this 50 ml is not going to remain there. It is going to seep into the interstitium. But if you are giving an albumin, the whole thing is going to remain in the intravascular compartment. And so there will be good correction of hypovolemia that is there till this albumin gets filtered off in the urine. That is the problem with IV albumin. The moment you give, after few hours, all this albumin is going to be filtered and lost in urine. So it is a temporizing measure. It is not a corrective measure that you are giving albumin. So for this child with a GFR of 40 ml per minute, it is little risky in giving IV albumin if he is not having a good urine output and if he is not having a good volume in the intravascular compartment for keeping this albumin. We never know whether this child is already in established AKI and is on the verge of fluid overload. So what are the gadgets that will help you to assess the intravascular volume? So if this child is admitted in ICU, I will definitely tell my resident to do this investigation also before, do this assessment also before we venture to give IV albumin, because the GFR is 40. If the creat is 0.5 and the urea is 61, I will definitely say the child is hypovolemic, you just push it. Push albumin, you give albumin. But now 0.9 creat is making me a little jittery. And so I will ask the resident to look at some more investigation or some more procedure before I give IV albumin order. What is that?
You want to look at the IVC?
Yeah, exactly. You are good. So you will be looking at the this IVC status to assess whether whatever albumin I am going to give can be, there is space in the vascular tree for holding that. That is called space assessment in the vascular tree. So that is also important for this child. So looking at the investigations are giving, this investigation reports are giving us a better idea regarding the clinical status of this child. So do you want to modify your diagnosis after seeing these investigations? All the investigation, child is having 2 kidneys, a 3-year-old child with a 7.3 into 2.7, 7.7 into 3.2 centimeter kidney. It's actually a reasonable good size kidney. Maybe little bit of nephrosarca is there because I will be expecting some 6.5 to 7.5 in that range, but little bigger, but not very big. Normal echo texture, CMD maintained. Okay, so what modification in the diagnosis you will make now?
AKI. AKI.
Yeah. So you're going to add acute kidney injury as well with hyponatremia and hypoproteinemia, hypovolemia. Okay, still hypovolemic. So what are the indications to give IV albumin? What are the other indications to give IV albumin?
Hypovolemia, diuretic resistant edema.
Hmm.
The edema does not
Diuretic resistant edema, again you have to look for established AKI and the volume status in the vascular tree before we give IV albumin. So thrombotic episodes, you will be giving genital edema.
Yes.
Then situation like this, severe hypovolemia, loose diarrhea, shock. Then mesenteric ischemia. Okay, but you have to understand that albumin is a double-edged sword. If I make a statement like that, do you agree with me?
Yes.
Yes. In what way? Giving IV albumin right and left and center for a child with nephrotic syndrome, especially so in a steroid-resistant one, is not good. Why? Unless there is a definite indication that is there. What will be the future of the albumin that you have put into the body by giving an albumin infusion? It will help to improve the intravascular volume. It will draw fluid from the interstitium to the intravascular compartment. And this fluid is going to happen in next 4 to 6 hours of giving IV albumin. So you will be giving albumin over 4 hours, and after another 4 to 6 hours, your albumin infusion was over by around 7 p.m. And by 10 p.m., 11 p.m., you are getting a call from the ICU telling the child is in severe respiratory distress. So remember that the fluid, pulmonary edema. So fluid shifts have occurred, will occur in the next few hours, not immediately after giving IV albumin. And once that fluid shift is happening, you have to understand that not only that 100 ml or 1 gram per kg of albumin that you are giving is to be held in the vascular tree, but the fluid that is seeping in from the interstitium also will have to be held in the vascular tree. So there has to be enough space in the vascular tree. So we have given, and the child has not gone into pulmonary edema, good output is there. So what is happening to the albumin now? Whatever you have given is going to be coming out filtered by the glomerulus. It is filtered by the glomerulus, and now the albumin is now coming into the proximal tubule. The proximal tubular cells are going to take up the albumin. So whatever proteinuria you are seeing, it is only a very minuscule amount of filtered protein that you are seeing in the urine, majority of which is reabsorbed in the proximal tubule, metabolized, and it is taken to the amino acid pool for utilization for further synthesis of protein. So once this is happening, the albumin molecule that you are giving, the child's albumin is only 1 gram per deciliter. So the filtered albumin is now very less. But once you are giving an IV albumin, the filtered fraction will increase, and that will be taken care of by the PCT cells. So there will be a tubulotoxicity by this albumin, which will destroy the proximal tubular cells. So will result in more progression of the kidney disease or kidney damage. So that also we should remember when we are giving albumin infusions, not for a responder, but for a resistant one. Okay, continue. Any further investigations that are there?
No.
This is over. So final diagnosis and the management. We have another maybe 5 minutes to conclude. Is the time up, Jose?
No problem, madam. No problem. Time is there. No problem.
It is going to be 9:30 in another 10 minutes.
Yeah.
So we have to wind up by then, no?
Okay.
Okay. So regarding the management, final impression, we have already. So do you want to say the final impression once more and then decide on the treatment, Ria?
Yes.
How will you manage this child now?
Since this child is now probably a case of high dose dependent nephrotic syndrome, right now presented in shock with AKI. I would want to continue, but I would want to add on a steroid sparing agent.
No, Ria, you cannot add on steroid sparing drug at this point when the child is in AKI, child is in sepsis. So how will you manage?
Madam, if PPT is over, we can stop the sharing and we can discuss directly. PPT said further.
PPT എടുത്ത് മാറ്റിക്കോ. ഒരു സ്ലൈഡ് കൂടെ വല്ലതും കാണുമായിരിക്കും. റിയയുടെ ഒരു താങ്ക് യു സ്ലൈഡ് കാണും. റിയ അതുകൂടെ പ്രസന്റ് ചെയ്തിട്ട് അങ്ങ് വിട്ടോ. സ്ലൈഡ് ഷെയറിംഗ് നിർത്തിക്കോ. നമുക്ക് അല്ലാതെ ഡിസ്കസ് ചെയ്യാം. Stop sharing. See, at this point, all of us have to remember one thing. This child is in a critical illness now. So managing the critical illness is the first point, point number 1. So how will you do that? Second is how to induce remission for this child at this point. So only after infection is cleared completely, you can induce a remission. And after inducing remission, the third thing is how to sustain the remission. So there comes the third line or second line drug. You understand? You have to choose from among the second line drug which one. That also has to be decided. So the first level management, this acute critical situation, how will you manage? You say that first.
So we have to resuscitate the child. For that, we have to give oxygen therapy, stabilize, to support the shock, and then give an IV NS bolus at 10 to 20 ml per kg over 20 to 30 minutes. A single bolus can be given after assessing the IVC to assess the volume status, and after the bolus also is to assess the IVC to check the volume status. And shock persists, one more bolus may be given, and after that IV fluids have to be continued. And we have to give IV albumin.
Ria, you are not remembering that this child is a nephrotic child. If I am asked, I will say I may give one bolus normal saline followed by IV albumin. You understand? The more saline you are going to give, you are going to make this child more and more edematous. Okay. And I will also be having a check on the urine output. When I am resuscitating a child in shock, I will be having definite, I have to look at the output, because the fluid overload percentage also you will be remembering. Whatever you are giving, whether it is coming out or not is important. And your BP status improvement is important. Okay. So after giving albumin, one bolus fluid in a nephrotic followed by one IV albumin. If you are not having the facility to mobilize for albumin, which may not be available in the periphery, then you can give multiple boluses. But after the second bolus, you have to be careful. Already we have seen that the investigations are not there with you when the child is in front of you. By the time you get the investigation, you will realize that already an established AKI is there. So the urine output monitoring is very important. Okay. Okay. So you have given fluid boluses, the BP improved, the urine output is 0.5 ml per kg per hour is there. And now what else you will be giving? Supportive medications?
IV antibiotics.
Yeah, definitely you have to start on IV antibiotics. That is also a definitive part of the treatment. Okay, which antibiotic we will choose?
Ceftriaxone.
You will give a broad spectrum antibiotic. Third generation cephalosporin is good. Okay, then what next?
IV steroid.
Yeah, you will be giving this child a stress dose of steroid. What do you mean by stress dose of steroid?
100 milligram per meter square per dose.
You can give which one? Which one? Hydrocortisone? You will be giving, you can give hydrocortisone, you can give betamethasone or dexamethasone, you can give oral prednisolone if tolerating, but child in shock, you will prefer to give IV steroids. Okay. Okay, then this is stabilized, the shock is stabilized, child is better, and then you will be, after the infection is controlled, you will be stepping up the steroid. After the infection is controlled, you can step up the steroid, induce remission. So till induction of remission, resolution of AKI and shock and AKI, induction of remission, things are, standard and okay for this child. This child problem is withdrawing steroid, it is not possible. So, and a very high dose steroid dependence. So which drug to use now? That is the next question that we have to ask. So what is the second line agent you will be choosing? The pros and cons of choosing the second line agent is important. So what are the molecules that are available with us?
Not used here, but levamisole.
Levamisole. Okay, levamisole. Let us now name the drugs. Levamisole, I agree. Second one? Cyclophosphamide. Okay. Third one? Mycophenolate mofetil. Fourth one?
Calcineurin inhibitors.
Calcineurin inhibitors, tacrolimus, cyclosporin. Fifth one? Rituximab. So in this particular situation, with an AKI that is there, and the child might be just recovering from AKI, serum albumin is only 1, really hypovolemic state, will you prefer to use CNI? No. CNI is at this point, at this level, CNI is going to be more problematic. Child is in shock, sepsis. Will you use MMF? No. So we have to actually, this child has to be stabilized, child has to come out of AKI, child has to come out of the septic shock, the diarrheal illness, the SBP, whether it is there or not, everything has to be settled. And once you induce remission, you will reassess the status and then think of the drug. Levamisole, is it good for a high dose steroid dependent nephrotic syndrome? No. Cyclophosphamide with so many infections that are there, severe pneumonia requiring hospitalization, ICU care. MMF, cyclophosphamide and all are drugs that can produce leukopenia and increase the risk of infection. So we have to be cautious with all that. And high dose steroid dependent nephrotic syndrome, with this much high dose dependence, if compliance is not a problem in this child, compliance issues are not there, child is already Cushingoid, this high dose steroid dependent nephrotic syndrome, at this point of time, we will be considering the CNI bar MMF bar rituximab, very young age. So rituximab is again a little problematic. Rituximab can cause, side effect profile of rituximab is serious infections, severe persistent hypogammaglobulinemia, then PML, progressive multifocal leukoencephalopathy, and interstitial fibrosis of the lungs. So many complications are there, but still it is a very good drug in a child who is free of infection, who is stable, otherwise high dose steroid dependent, little bigger child, especially adolescent time and all, when you want to get the height velocity maintained, you can go for that. So for this child, which will be better? This child, the possible drug that can be chosen is, one is MMF, once the infection is completely cleared, or you can think of doing a renal biopsy and choosing tacrolimus or cyclosporin. Okay, we have to remember that every molecule that we use in nephrotic syndrome is good, at the same time is having bad side effects also. So we should be knowing the drug and what to monitor, how to go about the drug, what are the expectations that we will be having. All this should be there with us before we venture to start such molecules. So I think this is the time for 5 minutes for discussion, queries and questions. Anybody can ask any doubt that is there.
Madam, can you enlighten regarding how to give the vaccinations when the child is diagnosed to have an nephrotic?
Okay.
From the initial phase on.
Yeah. That is very.
Most of the time. Am I audible, madam? And Suresh?
Yeah, you are audible.
Audible.
That is
Audible,
a very.
audible.
Yeah, that is a very practical question that you are asking. Actually, nowadays, no pneumococcal vaccine, if it is not given, already, I think we should be giving the pneumococcal vaccine. The pneumococcal vaccine usage is actually not nowadays limited by the steroid dose that the child is on. So we can give. See, all the killed vaccines nowadays, we say that you give even when the child is on a higher dose of steroid, no problem, we can give. But the live vaccines that we have to give, we have to be choosing and we have to be seeing the dose of steroid. It is better to have the vaccination while the child is off steroid for at least 4 weeks. That is the best time to give. But usually some children, we may not get an opportunity to give the vaccine like that. Then while the child is on alternate day steroid therapy for at least 4 weeks, and the dose of steroid is less than 20 milligram or less than 0.5 milligram per kilogram alternate day, you can give the vaccine. It is better to vaccinate rather than not to vaccinate. IPV is available, so OPV is not a problem. We can give IPV. And annual influenza vaccines, killed influenza vaccine should be given to all kids with nephrotic syndrome on Any immunosuppressant, whatever is there, the annual viral vaccine should be given. The flu vaccine is given regularly to all people in the Western countries, but now we don't give. But it is very useful. You can give to all children. A killed influenza vaccine should be given in the month of August or September every year to all children with nephrotic syndrome or other diseases where you are giving a long-term steroid therapy. And then while on MMF, cyclosporin, tacrolimus and all, then there is again a problem. Now the guideline is to give these vaccines once the child is on alternate day steroid, and after stopping this cyclosporin, tacrolimus for at least, and MMF for at least 3 months, and post rituximab after 6 months of post rituximab. Usually by 6 months the B cell recovery happens, then you can give. We should vaccinate. We should not withhold the vaccine.
Okay, thank you, madam.
Dr. Susan, one comment. The dietetic management in view of this high cholesterol also may be mentioned. And one point for the association level, because national level nephrology chapter should take up this to the National Technical Advisory Committee, so that modifications can be done, because all kids are ours, because they are the people who need these special vaccinations. At present, there is no provision for pneumococcal vaccine to be given above 1 year, but these kids need it. So we should have a policy to provide these kids the national immunization schedule vaccines, a little relaxation for age or for that group. Another thing, as you rightly pointed out, better to give the advantages on the safer vaccines. The efficiency may be 50% or 40%, but they are safe. When they are safe, give it and later time for a second dose. So that would have been a better policy.
Yeah, exactly. Rather than withholding. That is what is exactly happening now with the changing guidelines. Previously, we were little reluctant to give vaccination at all. But now, even when on alternate day steroid therapy, killed vaccines should be given and can be given. And another point I wanted to say is, there is one question. What about using levamisole in this child? Remember, levamisole is a good drug only for frequently relapsing nephrotic syndrome and intermediate dose dependency. Levamisole is not beneficial for such high dose steroid dependent nephrotic syndrome. This child, I am really doubtful about the that last few months relapses which were happening at 1.5 milligram per kilogram, because usually what is seen is the threshold dose usually won't change. If it is 0.75, it usually will remain at 0.75. If it's at 0.5, it remains, unless there is an ongoing infection that is there that is preventing the child from going into remission. So that last history of continuing relapses without much reduction in steroid is little doubtful. Anything more?
Madam, regarding the levamisole, also there is a two guidelines, sir. Alternate day and daily regime. And what about your opinion? There is a
we do give only alternate day levamisole. There was one study that came from Chennai, from the Namalwar group, and when Dr. Vijay Kumar was there, they made a protocol where they were giving daily levamisole. And a comparative trial was done where they found that it is more effective, but that is not taken in a wide manner by everybody, not accepted. And one problem with levamisole is we have seen cases of agranulocytosis. Two kids, and agranulocytosis, one child, it was so bad that only symptom was the child was not feeling well. That is the only symptom. The child was not able to get up, not feeling well at all, very lethargic, no fever, nothing. And levamisole of 2 weeks, alternate day, check the count, the neutrophil count was only, ANC was only some 100. And the next day, ANC was 0. I had to give GCSF to that child. And recently also we came across one child who came with granulocytosis. Unless and until you check the TC, you're not going to even make a diagnosis. That is another thing. You will not get any clinical signs. You will be telling over the throat, you may get some what patch may be there. Nothing was there. Only symptom was child was started on levamisole 2 weeks back. Steroid was getting withdrawn, and the child came back with no fever, nothing, no reaction from the body. Was very tired. So sometimes you may come across such situations. So levamisole is, you may think that it is a, till I saw that child, I always felt that why to do the TC every time this child is coming for follow-up. So what advantage is there to poke the child each time and do the TC? But once you see that, no, then MMF also similar. Yeah, MMF also you have to monitor the count.
Now madam, what is the calcium inhibitor? Now the recommendation is don't need to do biopsy before.
Exactly. They see all the guidelines may change. All our guidelines and all our treatment protocols keep on changing. And actually, in steroid-resistant nephrotic syndrome, you have to do renal biopsy, provided there are no other features to suggest a genetic nephrotic syndrome. Like sir was telling, if there is a dysmorphism is there, microcoria is there, or ambiguous genitalia is there, don't do biopsy. You know the diagnosis is genetic. You do the genetic evaluation. Other steroid-resistant nephrotic syndrome, whether it is a primary SRNS or a late SRNS, primary or primary SRNS is first time only the child is not responding within 6 weeks. The late SRNS means an initial responder, then subsequently became resistant. So both these you have to do the renal biopsy to see what exactly is happening in the kidney. But for a steroid-dependent nephrotic syndrome, high-dose dependence also, by doing a biopsy, it is our experience also is that you may get only MCD. Nothing will be there, only MCD, or some amount of mesangial hypercellularity, which is not going to actually give you any base to change the final diagnosis or final treatment. So the doing a renal biopsy before CNI will go. It will go in within the next few years. We will not be doing it.
Regarding the renal biopsy below 1 year, up to 3 months genetics only, and from 3 months to 1 year genetics followed by, if necessary, biopsy.
Yeah, exactly. But after 6 months and all, sometimes see below 6 months, definitely you have to do genetics as well as if genetics is negative biopsy. But after 6 months, we have seen children presenting at 8 months and 9 months who are steroid responders. If they respond to steroid, there is no need to do the biopsy at all, even if the age is below 1 year, but beyond 6 months. We have got some 4 or 5 kids who presented at the age of 10 months, 8 months, who responded well and whose the trajectory is also good.
Madam, one more regarding during the nephrotic syndrome follow-up, including minor illnesses, whether it's any role of looking for hemo concentration, concentrating on PCV and all.
If in relapse, if the child is in remission, there is no point. No, not needed. Yeah. Not needed if the child is maintaining remission. And also during infection, you have to give the daily steroid therapy. The study from Japan and one study from Germany, they actually didn't find the benefit of giving a daily steroid therapy. For example, a child with steroid-dependent nephrotic syndrome on 20 kg child on 10 milligram alternate day, developing an infection, you can give 10 milligram daily for 1 week. So the AIMS group has shown that by doing like that, by stepping up the steroid to daily from alternate day, you're preventing a relapse. That was the result of their study, but this was not well accepted abroad. And so that is why IPNA, International Pediatric Nephrology Association guideline has not included this changing to daily steroid for infection, whereas ISPN has included that as one of the guidelines. This, you understand, daily steroid therapy during infection for a child who is dependent or frequent relapser on alternate therapy. We are giving. We find that it can prevent a relapse.
Madam, and one thing, hemo concentration looking for a PCV and all. A child having a illness, concurrent illness during a nephrotic syndrome on remission, child having a looking whether in role in looking for hemo concentration.
That is what I am telling. Yeah, if the child is in remission, the child will be behaving like any other child. So dengue, you have to look for hemoconcentration, not for other diseases. You have to ensure that this child is maintaining remission during that episode of infection. Going into relapse, there is always a risk of hemoconcentration coming. If in remission, no problem. And I wanted to discuss about Sir's question also again, this cholesterol and nephrotic syndrome. So cholesterol and nephrotic syndrome, again, this atorvastatin is actually recommended above 8 years of age in children who are having steroid resistant nephrotic syndrome. Not even this frequent relapses and steroid dependence. But we have done one study where we found that it was Dr. Prashant, our gastroenterologist, his thesis, where we found that for a child in relapse with a high cholesterol, for the cholesterol to come down to normal, it may take more than 3 months. So in that 3 months, if the child is developing another relapse, so around the year, a child with frequent relapses, child with steroid dependent with number of relapses or more, they are also at risk of having this hyperlipidemia throughout the year. But the guideline is not recommending the cholesterol lowering drugs. And even for SRNS, the guideline is if the LDL cholesterol is more than 160 or LDL cholesterol more than 130 with other cardiovascular risk, you have to give atorvastatin 10 milligram to 20 milligram if the child is above 8 years. But for SRNS, even below 8 years with very high cholesterol, we are using atorvastatin. The dose of atorvastatin milligram per kilogram is also not mentioned anywhere. It is pediatric, it is recommendations are not there. So, but dietary modification is possible in the sense that you can give less than 10% of the total calories can be from saturated fat if high cholesterol is remaining.
One clarification from Ria.
Yeah.
Because Susan said in the last 3 relapses were in high dose steroids. So was the child getting syrup or tablet during the period? Because this week, on Monday only, I got a patient. Patient was advised to take 15 milligram per 5 ml of prednisolone syrup. And that is 7 ml he was supposed to take. And he was getting the strength of 5 milligram per 5 ml. And he got relapse there. And parents, unfortunately, mother is not here. The father and some other lady bystanders are looking at the child. That also you have non-compliance in a column. You have to check those things also.
Yeah, exactly. Syrup shake again problem.
Adum binne strength.
No, strength. Yeah.
Strength important.
Strength important. Okay.
Susan, madam, one thing about the diet I want to know. Yes, sir. Is it still recommended to give egg whites daily?
Yeah. See,
most of our people are doing that. Most of our mothers are doing that. That's why I'm asking.
ഒരു മുട്ട 2 മുട്ട 4 മുട്ട വരെ കൊടുക്കുന്ന അമ്മമാരുണ്ട്. The total protein requirement actually high protein required അല്ല. Normal protein diet ആണ്. Normal protein diet ആണ് നമ്മൾ അഡ്വൈസ് ചെയ്യേണ്ടത്. അപ്പം നമ്മൾ egg white കൊടുക്കാം. It is good. It is a high biological value protein. അതുകൊണ്ടാണ് അപ്പം നമ്മൾ കൊടുക്കുന്ന പ്രോട്ടീൻ മുഴുവനും egg white ആക്കിയാൽ it should not become a high protein diet. Egg white കൊടുക്കുന്നതിന് കുഴപ്പമില്ല. Egg white can be given, fish can be given, chicken can be given, but all together should be in the recommended daily allowance. Recommended dietary allowance. അത് കൂടുതലാവരുത്. അത്രേ ഉള്ളൂ.
Thank you, madam. Excellent discussion. I think more than almost
no more
2 hours.
We can wind up almost
2 hours.
2 hours. Okay. Yeah. Thank you for this opportunity to interact with all the postgraduate students, which I actually miss. I'm not getting that.
Class, online class.
Okay.
Thank you, Susan, madam.
Once in a while, we will conduct this CME on Zooms, madam, so that we can have classes.
Yeah, that is true. That is
not only on nephrotic syndrome, other renal problems also.
Okay.
Sharma sir, any concluding remarks? Sharma sir, any concluding remarks?
Okay, nothing. Okay. It was an excellent presentation by the PG So an excellent discussion by the faculty. So none other than Susan madam can do like this. So
Ria നന്നായിട്ട് present ചെയ്തു കേട്ടോ. Ria's presentation was
very
good.
good presentation.
Yeah, very good.
Confidence.
And also this kudos to Ria's mentor also.
Mentor NMC ഇതിന് പോയിക്കുവാണ്.
സൂസൻ മാഡം ഞാനത് ക്രിസ്റ്റിനെ കണ്ടിരുന്നു. നമ്മുടെ നെഫ്രോളജി സ്പെഷ്യാലിറ്റി കേസിനാര് നടത്തുന്ന കാര്യം. മാഡം ഞാൻ ഡേറ്റ് സൂസൻ മാഡത്തിന്റെ കൺവീനിയൻസ് അനുസരിച്ച് ഫിക്സ് ചെയ്യാൻ ഞാൻ പറഞ്ഞിട്ടുണ്ട്. ഡേറ്റ് കൊടുത്തിട്ടുണ്ട് ഞാൻ സൂസൻ ക്രിസ്റ്റിനെ കൊടുത്തിട്ടുണ്ട് ഡേറ്റ്.
Okay then. Okay. Good night.
Thank you.
On behalf of IAP Kottayam and IAP Kerala, I extend my sincere gratitude to Susan Madam for this wonderful class. I would like to express my gratitude to Ria also and Sridhara Madam for bringing out this case so that it can be discussed well in this forum. Thank you. And again, Pindali Madam, Josa, Purushottam sir, and all the senior faculty being present throughout the sessions. Thank you.
Thank you. Thank you all.
Thank you.
Bye.
Night.
Bye.
Good night.
Bye.
Good night.